Hello, everyone. Welcome to our consumer education series, treating depression with dialectical behavior therapy. Before we get started with our presentation, I would like to just provide you with a quick overview of Clearview treatment programs. Clearview was founded in 2000, still independently owned and operated by Michael Roy, LCSW. We provide a full continuum of care, including detox, residential care, day treatment, intensive outpatient, and individualized outpatient. We are Joint Commission accredited. Our focus is on evidence-based practices, which include dialectical behavior therapy, cognitive behavioral therapy, acceptance and commitment therapy, seeking safety, motivational interviewing, prolonged exposure therapy, and the matrix model. It's relapse prevention and education for addictions. We do several trainings and are very proud of our collaboration with Yale University and faculty on program outcomes studies, which we are currently going to have some findings for the Women's Center soon, so it's very exciting. Do intensive DBT trainings by behavioral tech and qualifying training institutes and trainers. Ongoing clinical training and consultation with thought leaders such as Charlie Swenson, Alan Frusetti, program development and weekly consultation with Charles Swenson, and working on DBT certification for our therapists and program. Under the Clearview umbrella, we have 3 programs, including our Center for Addictions and Dual Diagnosis. There's a residential program, which is co-ed for men and women, primary addiction, and co-occurring mental health disorders. We see anxiety, including PTSD, personality disorders, eating disorders, which are, we don't treat as a primary, but we do often see as a secondary. So we have a dietitian available in all of our programs to help those who need that. We're a small, intimate environment, primary care and extended care. We're located about a mile from the beach. All our therapists are on site every day. We offer comprehensive DBT and other evidence-based modalities, including matrix model for addictions, intensive group and individual therapy program, which is designed to help clients integrate back into life. Our second program is our Women's Center for Emotional Dysregulation. It's a residential treatment program for women with borderline personality disorder and emotional dysregulation. But we also treat other mood disorders, anxiety, PTSD, and other personality disorders. It's providing comprehensive DBT, which entails skills groups, up to 3 individual therapy sessions a week, milieu and phone coaching, and consultation team. Other therapies include CBT, ACT, and prolonged exposure therapy and seeking safety. Step down for this program and our dual program includes PHP and IOP, which is located in Westwood, so not too far from here. In that outpatient center, we have a PHP program, which is 6 hours a day, 5 days a week. Intensive day and evening outpatient program, which is 3 hours per week, 3 to 5 days per week. Individualized outpatient program, customized based on the client's clinical needs. So with collaboration with the outside referent and our intake team, who can decide, and from a constellation of many groups, what's most appropriate for the client. All programs include individual therapy and case management, psychiatry, and dietitian if needed. I think I just skipped one. Okay, sorry. Our family programs include family support groups free at our outpatient center weekly. It's open to the community based on availability. We have a 5-week DBT family education skills group here at our Women's Center, which is facilitated by our clinical associate director, Nicole Riddle. And that just goes for 5 weeks and just keeps repeating itself. We have an intensive 2-day family program, at our dual program, an intensive DBT family skills weekend, and individual family therapy in all programs as needed. Okay, just keep going the wrong way, sorry. Okay. We do lots of workshops and trainings such as this one, this community education series for consumers, family members, and providers. We do workshops in conjunction with national trainers and training institutions, sponsorship of national conferences, and services to hospitals, institutions, counseling centers, and universities, and speaking engagements local and national conferences. We accept many PPO out-of-network insurance. We are in network with Anthem Blue Cross for our residential dual program and our PHP and IOP. Not in network for here at our Women's Center. Insurance services, we provide our verification of benefits, pre-authorization, utilization review, and billing. Okay, before we move on, and I'll introduce you to our presenter, Kate, our upcoming community education events. So you can visit our website. They're all listed there, but we hope to see you at another one. We have one coming up in June, June 20th, the warning signs of addiction and how to get a loved one into treatment. September 19th, signs of anxiety disorder and how to treat anxiety. And in November 21st, DBT for substance use, how DBT helps people in recovery. So you can please visit our website and stay tuned for all of our events and sponsorships. So without further ado, I will introduce our presenter. Kate Rohrig received her master's degree in clinical psychology with an emphasis in marriage and family therapy in 2002 from Pepperdine University. Kate is a licensed marriage and family therapist. Kate has been a member of the Clearview team, the Clearview Women's Center since 2012, starting her work as a community counselor and moving into a position of house manager. As house manager, Kate worked closely with the treatment team to ensure the client's experience upheld Clearview's mission and values. Kate has been a DBT therapist and skills group facilitator at Clearview for several years. She facilitates DBT skills groups, CBT groups, and provides individual therapy and skills coaching utilizing DBT. Kate is trained as a National Education Alliance for Borderline Personality Disorder, Family Connections Leader, and co-leads family programs offered here at Clearview. So welcome, Kate. Yeah.
Let's go ahead and get started. So tonight we're going to talk about using dialectical behavior therapy and application with depressive disorders and symptoms related to depression. So there's a lot there. I'm going to do my best to really hit on the highlights and go into detail with specific interventions related to DBT. And first, I'll talk a little bit about specific depressive disorders, the traits that go into the criteria for making a diagnosis of major depressive disorder. And then we'll kind of funnel down into more specific. So we'll start out pretty broad and then we'll funnel down. So if you have questions, please save them for the end if you can, because we might cover it as we go through. Can't get it to move. Is it the space bar with this one? I was doing the arrow, but it wasn't moving. Oh, there.
Yeah, there it goes.
There. Okay, thanks. All right, so some of the main depressive disorders that you'll see if you're looking at the Diagnostic Statistical Manual for Mental Disorders. These are some of the main ones. You'll notice that bipolar depression is not included in there. We're going to focus on unipolar depression tonight and depressive disorders related to that and not look at the hypomania and mania side of things, because that would be a whole other topic and that would be quite a while of us going through that. So we want to be really thoughtful about the application of these specific interventions and skills related to DBT and give you as much as we can pack in to this amount of time. So some of the main depressive disorders that you guys probably are familiar with is, of course, major depressive disorder. I have included in there that even with major depression, you can see a mixed or anxious mood. So not bipolar depression, it can be major depressive disorder with mixed and anxious mood. Peri or postpartum depression, this is of course related to what a woman may experience around prior to giving birth as well as after giving birth. Persistent depressive disorder or dysthymia. So this is the chronic kind of lower level depression that you're gonna wanna see 2 years of this, and it's gonna be, again, like lower level symptoms than major depressive disorder. Premenstrual dysphoric disorder. This is marked in the sense that it's not your typical experience of symptoms that occur prior to having menstruation. It's going to be something that you see a marked increase and intensifying of the symptoms of PMS before, and then you see it greatly reduce after. Seasonal affective disorder. This is, of course, going to be when we get in those grayer, more wintry months of the year. You're going to see a shift in mood, and that will clear up as we get into the spring months or the summer months. That is something that's very common more in like the Midwest or the East Coast, not so much out here, you know, where we have more of a stable weather system. And grief and bereavement, this is going to be different than major depressive disorder. The quality of this is going to be different because in major depressive disorder, you're going to see more of the negative self-talk in major depression. In grief and bereavement, you will see a lot of similar symptoms. The difference is going to be that it's really surrounding loss. So a person may experience suicidality like what you'd see with depression, but the suicidality might be more focused on wanting to join a loved one who's recently passed away. Whereas major depressive disorders, you're gonna see the suicidality centering more around hopelessness or a lot of negative self-judgment, feeling like a burden to loved ones. So we're gonna keep kind of getting a little more specific as we go. So criteria for major depressive disorder, this is what we're really gonna focus in on, is this is from the Diagnostic and Statistical Manual for Mental Health Disorders. So you need at least 5 symptoms present in the same 2-week period. And it needs to be a change from previous functioning. So it's not going to be that this is what you typically experience. It's going to be a change. And at least one symptom is either depressed mood or loss of interest or pleasure. So these criteria are depressed mood most of the day, nearly every day, which is reported or can be observed. So this might be a loved one who's very familiar with the person is seeing this shift in their mood. Diminished interest or pleasure in activities most of the day, nearly every day. Significant weight loss or gain or change in appetite, nearly every day. Insomnia, so difficulty sleeping, and the other end of the spectrum, hypersomnia, where it's really hard to get out of bed, really sleeping more than what's needed. And that needs to occur nearly every day. Observable restlessness or slower motor functions. Fatigue or loss of energy, nearly every day. There's a pattern here, nearly every day. Feelings of worthlessness or excessive guilt, nearly every day. Diminished ability to think or concentrate or indecisiveness, nearly every day. And then the last one, this is one that is, of course, the most concerning for people, is reoccurring thoughts about death. There might be, ranging from suicidal ideation of thoughts of people would be better off without me, to planning what they would do to end their life, to having attempts. So this one at the top says statistics, if you can't read that. So major depression is super common. It's so common that people will call it the common cold of mental health disorders. So just to give you a few stats around that, there's an estimated 16.2 million adults in the US that have had at least one major depressive episode. So that's a lot of people. That's like taking all of the people in the state of Indiana and all of the people in the state of Georgia, and they all have experienced major depressive, like one major depressive episode in their life. The prevalence of major depressive episode is going to be higher among females than males. This is true also for adolescents, which is one of the later statistics I have here. And the age range that we see depression pop up and be highest is in the age range of 18 to 25, which, if we were to guess, part of that could be that there's a lot of life transitions that happen during that time period. A lot of things, you know, you're kind of getting your footing and figuring things out as an adult. That can be really hard. And so that could be part of what contributes to that age range having the highest prevalence. An estimated 3.1 million adolescents, so that's the ages 12 to 17 in the US, have had at least one major depressive episode. That's really significant. And within that population, females again have a significantly higher prevalence of having had one major depressive episode versus males. So adolescent females have 19.4% versus males 6.4%. That's pretty significant. So let's break this down from not quite so clinical of language to kind of what we see on the surface, the common traits of depression that we see, that when clients come into treatment here, this is really the things that we want to work on and we want to target, as well as what we'll go over on the next slide. So persistent low mood, irritability and anxiety, that's something that can certainly come up with depression. It's not something that we always think of when we think of depression. So we might not always realize that's what's going on, if it's ourselves or if it's somebody that we know, that you don't always think of anxiety and irritability being connected to that. It's very much a common trait of depression. Slow or restless motor movement, physical pain and discomfort. There's definitely a mind-body connection. So if we're feeling really crappy mentally for a long period of time, that's going to have an impact on our biology as well. And often there can be like GI issues, there can be physical pain like in your joints, there can be lots of other health issues that come from that. Sleep issues, so that's what we were talking about earlier, that you might find that you're having difficulty sleeping or you're oversleeping. Loss of interest in things that previously were pleasurable or you found interest in some capacity. A change in appetite, difficulty concentrating, memory issues, difficulty making decisions, and then of course thoughts of suicide or suicide attempts. So this is what we talked about on the previous slide, but it's really kind of generalizing it a little bit more. So what happens is that we get, when we have these traits going on and these experiences, we can hold it together. We're pretty sturdy as humans, and over time it becomes life interfering. It has an impact, it has a ripple effect. Some things that you will commonly see with depression is that you're no longer able to meet responsibilities. If you imagine having a day where it feels almost impossible to get out of bed, how on earth are you going to even imagine getting to work, or if you have children, like taking care of your children or pets? That is like asking somebody to climb Mount Everest. So it becomes life interfering. The individual doesn't want that, but that's what happens. There's an impact on relationships, and that can come with irritability, that we might get in conflict with others because of what's going on with our mood. The loss of interest can lead to apathy around relationships. You might, it takes a lot of effort and work and contact to keep social relationships. And when we don't do that, it has an impact. You might lose significant relationships or impact them in some way. Over time also, again, we do our best to get through difficult moments, and over time, we may end up engaging in ineffective coping techniques. I've tried different things, it doesn't seem to work, I'm feeling really miserable, I don't know what to do. You might find ways that kind of temporarily put a Band-Aid on it or help you get through, and it feels effective, but long term it's not. effective. That might look like substance use. That might look like oversleeping, like you just kind of want to shut down, over medicating, etc. And then we already talked about that there can be a change in physical health. That can be very life interfering. So that might result in pain, GI issues, a change in weight, fatigue, sleep issues, which of course, for me, that's my kryptonite. If I do not get enough sleep, my ability to function the next day is greatly impacted. My vulnerabilities are through the roof. And you can imagine if that's something that's happening day after day, that really chips away at our ability to do much of anything. And that can lead to a downward spiral. So there are lots of treatment options out there. It's hard with depression to have the motivation or hope to even consider that this could change, because it feels like you're in a really dark place where that's not possible. And there are a lot of treatment options out there, and treatment's not a one size fits all. So unfortunately, another reality of it is you may have to try out some different things before you find what works for you. So tonight we're going to talk about specifically dialectical behavior therapy as part of a treatment option. However, with depression, medication management is often a big component of that. And we may get to the place where we're willing to try and go to a doctor and be vulnerable and say, I'm struggling with this. I do need, to possibly have medication as a support in what I'm experiencing. And we might not realize that even that step, that's huge and that's great, and that may be something that really benefits you. It can take quite a while for medication to get to a therapeutic level. So that's typically 2 to 4 weeks. So, and even within that time, you might have to adjust. You might not have the best response to the medication. You might need to switch it out. So that's certainly something that, you might have to kind of bear with the process. Psychotherapy, of course, is going to be important as well as a support for depression. Lifestyle changes are often needed. If we've, really become isolated in our depression and perhaps aren't eating the best as well, like not really taking care of our body either, we may need to really work on those things too. That if we have an environment where we're more removed from people, that's of course going to make it harder to move out of depression than if we, this is again not an easy task, but try to be around even if it's just one person. So there may be lifestyle changes that need to be made. And often a combination of these options is the most effective. So dialectical behavior therapy, or DBT, is an approach that has been shown to be really effective with depression and depressive disorders. This approach was created by Marsha Linehan specifically for really high-risk suicidal clients and self-harming behaviors, really specifically borderline personality disorder, which is what we specialize in here at the Women's Center. And what Marsha found as she was trying to figure out how to best treat this population was that when she first tried it, she went with acceptance alone, of really trying to be in the moment and validate where the clients were at. And this wasn't appropriate and wasn't super helpful because the risk was really high. And then she went to the other end of the spectrum of behavioral change alone, so more like CBT. And that didn't really work either because it felt invalidating. The individuals who were experiencing the high-risk behaviors and the emotion dysregulation weren't feeling heard and understood, just kind of pushed toward change, which didn't work either. So DBT is this balance, this marriage of both accepting where a person is at while simultaneously pushing for change. So we're constantly striving to find that balance through the interventions of acknowledging and validating and really trying to hear and understand and be with the person in their moment and what they're experiencing, while also trying to motivate them and give them tools to shift and have things look different over time. And so that's called a dialectic, being able to have two opposing things both be true. So with DBT, This is an evidence-based approach. Research has shown that this was, of course, developed for the high-risk suicidal behaviors and BPD, borderline personality disorder. Research has shown that this is a very effective approach for other disorders as well, including depression. So again, we're using a balance of acceptance and change-based skills. We're going to go through the different modules in DBT. There are 4 modules, which are specific sections of the DBT manual where you go through very specific skills and help teach the clients how to utilize those in their life and with what they're struggling with. And the balance is that some of the modules are acceptance-based skills and some of them are change-based. DBT also has what are called the DBT assumptions. And these are really, really important because when you're working with people who struggle with these chronic behaviors that are really impacting their lives and getting them to the point where they don't feel like life is worth living, that's a really tough place to be. And it's really hard to shift away from that space. So part of the work is around holding these assumptions. These are things that we want to keep in mind to keep us in that place of empathy and non-judgmental stance when it's hard to be there, when we want to maybe give up, when we feel like things aren't changing, that we're not doing, enough. So some of those assumptions, we're not going to go through them tonight, but some of them are everyone's doing the best they can with what they have. That's that acceptance. And then the other side is, and everyone needs to try harder and be more motivated for change. So meeting the person where they're at and also pushing for that change. Another DBT assumption is we need to have the most benign interpretations possible. That's really important too. We can come up with all sorts of ideas of what motivates a person and have all sorts of negative assumptions and judgments. And what happens is when we have those, it impacts us and it impacts our ability to be empathic and maybe to do something that's effective. So really having a more benign interpretation or another explanation for someone else's behaviors is going to have a more positive impact on how we're feeling. The example I'll give in family class when we go over these is if I'm driving on the freeway, trying to get home after a long day. You guys probably experienced this coming here. And when you go home, you'll experience it too. And if somebody cuts me off, I might have the thought of, oh my gosh, what a jerk. Like, why do they need to get home sooner than me? What's going on for them that's so much better? And if I go with that, I'm probably going to feel angrier and hold on to that more so than if I'm able to say like, oh, that was, I wish that the person wouldn't have done that. That wasn't very thoughtful. And maybe they have a family emergency. I don't know. That's a more benign interpretation. And that's going to allow me to move on a little more quickly and probably not experience as much anger or resentment than if I went the other way. And DBT is also very structured. It's very structured. There are different modes of treatment, which we'll go through. And we also, as therapists, follow a treatment hierarchy where I'll show you the intervention we use to help us set up that hierarchy so we don't miss something that's really important that had we not been tracking it, we might have spent session talking about something that wasn't as life impactful or important in the person's current life as, this other thing. And then DBT has many interventions and we'll go through some of those as well. So it's very structured. So the modes of comprehensive DBT. At the Women's Center, we do comprehensive DBT. If you're looking into programs and want a program that's comprehensive, it's important to ask if these modes of treatment are present. If they're not, then it's probably not a comprehensive DBT program. So the first mode of treatment is individual therapy. This mode's super important because it is what is meant to motivate the clients. We're in that room, we're talking about the really difficult things in relation to depression. It could be working on hopelessness and suicidality. The person might feel very hopeless and not feel like there's a way out beyond hurting themselves. And so individual therapy is this place where we really get to be with the client and really understand where they're at and get in that dark place with them and help motivate them to come walk out of that, hopefully. Skills coaching group is a mode of treatment that's meant to enhance the client's capabilities. So yes, the client's going to get skills, which are the tools to help them work on the target behaviors, the behaviors we're targeting while they're in treatment. They're going to get that in an individual therapy. They're also going to get it in group therapy, which is really great. It's a setting where you get to hear how other people are applying the skills and relate to others, and really work through what the different modules look like and practice them and come back and troubleshoot. Family sessions and case management. Family work is so important. It, you know, the things that people struggle with have an impact not only on themselves, it has an impact on the individuals that, you know, they're close with, and everybody just kind of looking for support and trying to figure out what is the most effective thing to do. So family work is extremely important in DBT. We want to involve, as appropriate, involve the individuals that are close with the clients so everyone can get that support and really navigate this together. And then phone coaching, this is another important mode of treatment. When a client has the ability to go off-site, so some of our women here at the Women's Center have privileges when they're a little further along in their treatment to go off-site. And they'll have their phone with them and they'll call their therapist if they're off-site and they're feeling kind of stuck and not sure what to do. And that's the opportunity for them to generalize skills. So they might be super familiar with the skills here, but this is kind of like training wheels a little bit in here. And then when they go off-site and they have passes, they get the opportunity to figure out and sometimes grapple with a little bit how to apply the skills that they know and are familiar with in here outside of there. And that can be super tricky sometimes. So it's a great resource and a very important mode of treatment for the client to be able to call their therapist and say, I'm trying to use this skill from distress tolerance. I'm trying to ground right now. And I'm having a really hard time. I feel like things are getting worse. I'm not quite sure what's going on. And they're able to get that support from the therapist and make a skill plan and get back to trying to apply it in whatever moment they're in. And then the last mode of treatment is consultation team meetings. So this is super important as well. Again, if you are interviewing different facilities or providers and want a DBT therapist, you'll want to ask them if they are a member of a consultation team, because this is a mode of comprehensive DBT. This is where providers get together and we put our heads together about our different clients, which I think is great because then we're really not missing anything. I may have an approach that or intervention that I am feeling could be super helpful with this client, but I'm not quite sure. And then one of my fellow therapists, Keely out there, may say, oh wait, Kate, did you think about this though? And it's so great because then we don't really miss things that we might have missed if we were operating on our own. So the goal of DBT, this sometimes is a shocker, it's not a suicide prevention program. It's not, which I know can be really difficult if somebody's struggling with suicidality. That can be a very scary thing to, you know, accept. What this is it's a program and an approach to help you build a life worth living, because the life that you're living currently, you know, when you come in and start DBT might be one that doesn't feel worth living at all. And so the goal is to really understand, define values, set goals, build relationships, build mastery, build those things into our lives, figure out how it works and how to apply it so that we have that life worth living. And this little graphic here is the DBT House of Treatment that shows often, like at the Women's Center in particular, they're coming in at that basement level. That is fire down there. It is hell. It is something that does not feel worth living. And so the goal is to keep moving up to get skills and commitment. And that ladder gets hot because you are sitting there in fire. So sometimes when we're doing the skills and we're trying to change behaviors, it gets really scary. The ladder is hot and you back off, you jump back down into the fire, and we got to climb back up. So that's just a depiction that we're moving through, and sometimes we go back down, and treatment's not linear. We sometimes have to come back, and we'll talk about an intervention where we look at when we possibly go off track, how we can learn from that to get back on track. So now we're going to go through briefly the 4 modules of DBT and what it looks like specifically with depression. So that says skill module mindfulness. This is a core skill module. This is really the foundation of all the other skills. And these are acceptance-based skills. So you'll remember I said that DBT is that balance of acceptance and change. There are 2 modules that are acceptance-based, 2 that are change-based. Mindfulness is paying attention to the present moment on purpose and with awareness and without judgment. That takes a lot of mindfulness. So some of the skills that we teach in that is to really practice being in the present moment without judgment, which means observing just what you can with your 5 senses. So instead of saying to ourselves, I don't like how hot this room is, I might observe that I'm feeling sweaty. I'm feeling my temperature come up. Do you agree? Yes. We might observe first. Observe is without the description. It's just noticing with our 5 senses. And then to describe would be to use non-judgmental language of, I feel my temperature increasing, something like that. And this is super important because in disorders, also including depression, we kind of get this warped and wonky filter, right? So what we describe might be super inaccurate from actually what's going on. The description might be, a lot of the women that we have that come through here say phrases such as, I want to die. I just want to die. And if we were to slow down and use mindfulness of observing and describing, well, what does that mean? Because when we get in this place of judgment and not using mindful, non-judgmental language, it can become super inaccurate, which will lead most likely to someone not getting a need met. There's going to be an inaccurate response. So if we really try to unpack that and observe and describe non-judgmentally, we might say, what does that mean? Well, I just feel so miserable. I don't know what to do with it. It feels like this is never going to end. Okay, that gives me more understanding. So is it that you really want to die, or is it that you don't want to feel that way anymore? You want that pain to end? Yes, that's what I mean. Okay, so that helps us kind of break things down. And another core trait of depression is negative self-talk, and part of what we do as well is we work on observing and describing non-judgmentally that language that comes up, because that has such an impact on mood too. So another module is distress tolerance. And this is an acceptance-based module as well. So we really want to go toward these skills when we're in a situation that is creating distress and we can't solve it right now. Or it's not effective to try to solve it right now, maybe because we're in so much distress. So these skills are super important to be able to get through those moments without things getting worse. That is the goal of all skills, just to have things not get worse. It's not that you're going to get relief immediately. Sometimes that can be a nice side effect from using skills, but it's just that we don't want things to get worse. And so distress tolerance skills are also not to be used for making your life worth living. Because if you imagine that life is just you trying to get through moment to moment, that's not really a quality of life. So when we're able to use skills such as acceptance, which is a really big part of distress tolerance, being able to not say that I like I like how I'm feeling, or I like what's going on in my life, but being able to say, this is what it is right now. I don't like it. This is reality right now. Acceptance leads to the ability to potentially change or work on the distressing experiences. So with depression, individuals experience a lot of misery and hopelessness, which can kind of move you into those crisis moments of suicidality or self-harm behaviors. And so with this module, clients get skills that help them to navigate those moments, like TIP, which we're not going to go into great detail with that. Psychologists love acronyms, so there are lots of acronyms in DBT as well. TIP is for changing your body chemistry when distress goes up real high real quick and we need to bring it down. This is a way to flip our body chemistry and kind of trick our body to calm down. So that involves temperature, intense exercise, and paced breathing and paired muscle relaxation. That's what TIP stands for. So that's really important and helpful. So when our gals here, for example, are having a really intense crisis moment and their distress is very high, we may walk them through using really cold temperature to help kind of shock their body a little bit. They'll do what's called an ice dive, where they put their head in a bowl of ice water up to their hairline, and it tricks the brain to think that we've just jumped into freezing cold water, we've jumped into the Arctic. And emotions aren't important in that moment. It's survival. So your body kind of goes into survival mode and calms itself a little bit. Emotions get shut off because that's not important when we're trying to survive. And what is important is getting blood to our major organs and getting our brain back online, because that gets compromised when we're very distressed. Also within distress tolerance is a very helpful intervention called pros and cons, where we try to look at, okay, if you're really wanting to stay in bed all day, let's look at the pros of that. Let's look at the cons of that. I'm sure there are things to speak to on both sides. And what might be the pros and cons of trying to do some things to get out of bed a little bit earlier. IMPROVE is another acronym in DBT where we're looking at different things we can do to try to have a difficult moment maybe get a little better, maybe. That involves imagery, making meaning out of difficult situations, using prayer or spirituality or mindfulness. Why am I blanking on the R? Relaxation. Thank you. This is why you're here, Keely. Doing one thing in the moment, doing something one mindfully, visualization, brief vacation. Good grief. My brain is like turning off at this hour. And self-encouragement. So giving yourself cheerleading statements or self-encouraging statements. And reality acceptance, which we talked about. This is, This is super important. When something is not the way that we want it to be, it's important to not say that's okay or that, I'm all right with that. It's to say it is what it is. If I'm not accepting reality, what's going to happen is I'm going to end up suffering, because reality exists. It is what it is. And if I push back against that, I'm taking something that's painful and I'm layering on top of it suffering. So another skill module is emotion regulation. The goal in this is to reduce emotional suffering through understanding our emotions, through being able to put a name to them and a label to them, to working on reducing vulnerabilities to painful emotions and changing unwanted emotions once they start. So this is a change-based module. The skills are change-based. And the goal is not to eliminate emotions, because that's not possible. And emotions serve important functions. It's to be able to be more mindful of them, like we're pairing mindfulness now with this, to be able to put a name to it. A lot of the times we spend so much time not being in touch with emotions, we push them away, and then we don't really know what we're feeling. And then to be able to have ideas for ways to change them once they start. So with depression, the things that come up, the struggles with sleep and eating and taking medication, sometimes we'll move toward coping by using substances or over-medicating. The lack of physical activity, this keeps us in that dark place. It feels like it's all we want to do, but what happens is we get stuck there and things get worse. So the skills in this module, such as another acronym, please, can help us to reduce our vulnerabilities by taking care of those things. So taking care of our bodies to be able to take care of our minds. And we'll go into more detail with that acronym, please, in a minute. Also, coping ahead, we're going to go into detail, a little more detail on that in a minute as well. So if we have the luxury, we don't always have the luxury, but if we have the luxury of knowing something tough is coming up, possibly, it is so helpful to cope ahead. And there are specific ways that we do that in DBT. So we'll again go into detail on that, but that can help to reduce the likelihood of a difficult situation when it comes up becoming, even more difficult or more painful. Accumulating positives is really important. That's also part of emotion regulation, that it's like putting pennies in a piggy bank, that if we're able to really mindfully be aware of something that's, even if it's just like a little pleasant, that we're putting that in a piggy bank, because with depression, it is, especially if you experience chronic depression, you're gonna have days that you just dip. That's gonna happen. And if you have these positives saved up in like a piggy bank, when those days come, it's not going to hit as hard, or maybe it won't last as long because we've got this saved up. Another skill such as opposite action is important as well. And this is where, especially with depression, like we want to not go toward the things that are like activating and being around people. That sounds horrible. Getting out of bed, I don't even think I can. Opposite action is an important skill that you use where you acknowledge that that may not be super effective in your life, and it by no means is this easy, but it's doing something different than giving into that urge. So it might be, I really want to stay in bed. I'm going to use opposite action. I'm going to just flip the covers off. And then maybe in a minute, I'll put my legs over the side of the bed, even though I really don't want to. So it's just, even in small increments like that, breaking it down so it feels more achievable, not giving in or capitulating with those urges that come with depression. Problem solving can also help reduce vulnerabilities. So if you know that there's a situation that's problematic, we might want to use the skill of problem solving, which is also very structured in DBT with a specific step-by-step of what to do to help you change an unwanted emotion that's related to a problematic situation. Okay. So the last module in DBT is interpersonal effectiveness. And this is a change-based module as well. This skill set's gonna help, as we talked about, depression can really impact relationships. It can make it really difficult to maintain them or can cause damage. So this skill set is going to help you to be able to build, repair, maintain relationships, and also effectively ask for what you need from others while maintaining self-respect. So there's a lot packed into this module, and it's super important. So to reduce and change the impact of what can come up with depression and relationships, identifying goals and interactions, that's something that you'll do in this module. Like, what do you really want from this interaction? Do you even know what you want? And help you to figure that out. Knowing when and how to use validation. Validation is such an important skill. It is demonstrating behaviorally or verbally that you understand, or you want to understand, or you're trying to understand, or that you hear somebody, that you're with them in that moment. And that can make such a difference, especially with depression, where it feels so isolating and alone. To be able to use validation and know how to use it and when to use it can be such an important intervention. Also within this module, we're challenging myths. So these faulty beliefs that we may hold about asking for what you need or want. You might hold the belief that, well, others should know what I want. I shouldn't have to say anything, or I don't deserve to get what I want or to ask for what I need. That might come up. So this helps us to identify those things that could be barriers, as well as skills to use around it. And also skills for navigating challenging and invalidating interactions are taught and practiced as well. So now, again, we're kind of funneling down a little bit. So we briefly went through the 4 modules of DBT. Now we're going to zero in on some of the interventions that we would use with an individual struggling with depression. So targets are the specific behaviors or experiences that we are kind of zeroing in on and wanting to work on. So we call those target behaviors. So with this specific example, the target is suicidal ideation or isolating, and we're using a diary card as an intervention here. The diary card is what helps this to be an evidence-based treatment. It's used to track these target behaviors, and it's the client that is the one that is carrying the diary card, and so it's a self-management intervention as well. They're the ones that are going to be identifying how high during the day did they experience suicidality out of a scale of 0 to 5. Well, most of the day I was at a 2, and then for 5 minutes it went up to a 3. We want you to write down that 3, even if it was for just 5 minutes, because we want to look at together when we get into session. This is again what guides the session and helps us set an agenda, that we want to look at what was happening in that 5 minutes so we better understand what prompted an increase in suicidality and then how to work on that, which we'll talk about the intervention that we might use there in a minute. So again, what I mentioned earlier is that with treatment goes by hierarchy. So if a client comes into session and on their diary card they've endorsed, they've written that they're having some suicidal ideation that they weren't before, but they're also struggling with overspending. Let's say that's another target behavior. We're not going to focus as much on the overspending. We might at the end of session, if we have time, we're going to talk about the life-threatening behavior experience of suicidal ideation. So this, we call it their ticket, or I do, their ticket to session. So if they don't have it completed for the previous day, when they come into session, I don't know what behaviors we might be missing if we don't complete that. So I ask the client to please fill it out before we start session, so we make sure that we're structuring the session how we need to. And this is a measure for progress. It's great. We can look back over time and see, like, wow, you were really struggling with isolating, 4 or 5 days out of the week. And now a few weeks in, after using these, different skills, you're isolating 1 or 2 days a week. Like, look at that. And so we can really kind of celebrate that progress with them. So this is an example of a diary card. It's very small. You probably can't see it. I can't even see it. It's right in front of me. There are lots of different examples of this. This isn't exactly the format that we use here. It does look very similar though. So you, if you're familiar with that, you might see a different format of a diary card. They're all similarly structured though, where you're going to track specific behaviors and the intensity of urges there. So another target and intervention is going to be, again, we're focusing in on suicidal ideation and isolating. And the intervention that we're now going to look at is called a behavioral chain analysis. So if a client comes in and on their diary card, they endorse, they write that they were experiencing an increase in suicidality. Like I was saying, we're going to focus on that first in session because that's life-threatening. So this intervention is awesome, and it's the bread and butter of DBT. This is where we look at what happened to prompt the increase in suicidality. So we want to identify what's called a prompting event. What was going on for you before that that might have made it more difficult to handle whatever it was? What were your vulnerabilities? What were the specific links in the chain? So how did we get from point A to point B over time? So we really look very closely at, with each slice of time, what were you feeling? What were you thinking? What was your body sensation that you could identify in that moment? What were you wanting to do? What were the urges? So that we can identify, like, oh, it looks like when that came up for you, when you had that thought, that's when your suicidality went up. I wonder if there's a connection there. So we can find red flags, we can look for patterns over time, and look at what might be reinforcing the behavior experience. So this is a graphic that shows a little bit about what that could look like. Again, there are different formats for behavioral chain analyses as well. And this is just one. So you can see the links in the chain going down to the problem behavior and the consequences there. So that's step one. We're just kind of looking at how do we get from point A to point B. And we do it very non-judgmentally. We don't, this intervention is not to look back and be like, oh, well, that's what you should have done. You know, it's to look at how did we get from point A to point B to point C, and how can we try to do differently in the future? And the how can we try to do differently is the solution analysis. So that's the second part of the intervention. So where can we make changes? If something similar were to come up again, what would we want to try to do or have in the back of our back pocket as a skill that might help us to stay on track or not go down that same path? So we look at the different links and we ask ourselves, you know, could I do something different here to lead me down a different path? And that's where we apply skills. That's where we might try to do some grounding skills. We might try to incorporate some mindfulness. We might do some other distress tolerance skills or interpersonal effectiveness skills to help go down a different path. So another specific target and intervention in DBT, the target behavior or experience that we're going to be looking at related to depression are sleep issues, change in appetite, lowered activity level, or not taking medications as prescribed. So this is very common in depression, as we've talked about. What we would target with this is using the acronym PLEASE. So when our body's out of balance, we have that mind-body connection, we're probably going to experience more vulnerabilities, higher emotion dysregulation. Things may be just more difficult for us. Please skills are going to help to increase our emotional resilience and reduce vulnerability to negative emotions. So these are kind of called like the non-glamorous DBT skills, because with some of the other skills, you're going to experience pretty, like if you go do an ice dive, you're going to feel some kind of a change in how you're feeling, versus with please skills, which are focused on like treating physical illness, making sure you're eating balanced meals or eating food that's helpful and good for your body that helps you feel good, avoiding mood altering substances, balancing sleep, making sure you're getting some form of exercise. Those are the skills that you may do them and build them into your routine and not feel a marked shift in your mood. What you probably would notice is that if you stop doing it, like I said earlier, if I stop getting sleep, like all bets are off. I'm gonna really feel that. So these are the skills that you might not notice a big shift as you're doing them. They are so important in helping reduce vulnerabilities. But if you stop doing them, you're probably really gonna notice a difference. Can you guys see that? Does anybody need, do you want me to go through and? Yeah. So the P and the L, I got a little liberal there with trying to make it work, is treating physical illness. So taking care of your body, seeing a doctor when necessary, and taking prescribed medication. So the E is balanced eating. You don't want to eat too much or too little. You want to eat regularly and mindfully throughout the day, and stay away from foods that make you feel overly emotional. If you know that there are foods that might make you feel not so great, trying to stay away from those. The A is to avoid mood altering substances. So staying off illicit drugs, using alcohol in moderation, or, you know, even if at all. This could also be caffeine. I know for myself, I run anxious, and so I also love coffee. And so I just make sure that I limit myself to like 1 cup a day, because otherwise I feel, you know, even more anxious.
Where's cigarettes fall in that?
Where's what?
Cigarettes, smoking cigarettes.
Smoking cigarettes? That would be in the mood altering substances. Yeah. Yeah. And then balanced sleep, trying to get 7 to 9 hours of sleep a night, or the amount that helps you feel good. That could be different for everyone. And it's really important to keep a consistent sleep schedule, which I know can be tough. Like I get up, 5:45 in the morning, don't really want to do that on the weekend. And I try to keep it close to that because that is what will help me to maintain my please skills. And then the E is to get exercise. So try to do some form of exercise every day. Try to get up to 20 minutes of daily exercise. You don't have to, go run a marathon or anything, but to do something that gets your body activated. Is that good? Yeah. So here's another worksheet that we go through in DBT group, where we might assign this as homework for the clients to look at, have I done these things? Keeping a record. So this is one version of that. This is another version. We have different, dependent on what we feel like the cohort needs, we might use one worksheet versus another one, or even within our individual sessions, we might have one of our clients use one of these versus a different one. So different ways to track and be more mindful of what am I doing with these? Am I, you might not even be aware, like, oh, I feel like I've had a cold for a week now and I haven't really done anything about it. That might be impacting me. So it's a nice little record to kind of increase mindfulness around. So another target and intervention, the target we're going to look at again is sleep issues, change in appetite, lowered activity level, not taking medications. The specific intervention that we might use with this is a cope ahead. So this really is a great intervention that allows for problem solving and planning ahead for really trying to navigate potentially difficult situations. So sometimes I'll have a client that will start a new privilege or something, like maybe they can go on pass, and they'll say, well, I'll say like, what could come up? Let's brainstorm. Anything, what might be tough? Even if you don't really think it will come up, what could? And sometimes they'll say, I might feel anxious being in a crowded area or taking an Uber, but I don't know, I might not, so we don't have to talk about it more. No, let's talk about it. Because if you think about with professional athletes, if you guys are familiar with this tactic, they'll very, very much in detail think about making plays, like really mentally, thoroughly go through detailed plays that they want to make. Because what happens is you're kind of tricking your brain to think, if you think in great detail, that you've already done it. So when you get into that situation, your brain is more likely to be able to access what you're wanting to try to do. You won't have to think as hard. It's going to kind of already be there as, oh, I've done this before. So that's why we do cope aheads. It reduces the vulnerability to the impact of potentially difficult situations, and it helps to increase resiliency and self-efficacy. So with DBT specifically, a cope ahead, you're going to describe the situation that's likely to prompt the problem behavior or a difficult moment. You're going to make sure that you're checking the facts, that it's factual, that it's not, judgmental language. You're going to look at the emotions that could likely interfere with using your skills. So in this situation, let me see. If we're trying to cope ahead with not going out on a pass, let's say that we are struggling with feeling like going out of the house, and we have an idea, we're going to meet up with a friend. The likely situation could be that we cancel on them because we really don't want to go out. We don't want to have to put on, get out of our PJs. We don't want to have to do the effort of driving there, which could be anxiety provoking, finding parking, all of that. So if the situation is that you might cancel, you might just back out, that's what we want to cope ahead for, those urges. So checking the facts, what are the emotions that could come up? Well, I might feel really anxious. And I also might feel irritated that I have to do this when I don't feel like it. Decide what skills you want to try to use. Be super specific. Well, I want to use opposite action. That's going to look like me putting on, you know, my clothes that I don't want to get out of my PJs, but it's going to involve me putting on my clothes. It's going to involve, you know, me getting into the car. I might need to take some kind of a distress tolerance item with me, like maybe my essential oils to help me kind of stay present and focused, where I'm not thinking about, you know, all these difficult things or kind of catastrophizing that they don't really want to meet up with me. Like, I'm not worth meeting up with. They're just trying to be nice because they feel bad for me. So really trying to prepare to challenge that. You might even write out a little coping card or a self-encouraging thing that says something like, I am worth meeting up with. They asked me to meet up and said they wanted to meet up with me. That, you know, might help to ground them or bring them back. Imagine the situation. This is the part where you're really bringing in that, that portion of what I was talking about with the athletes. Imagine it thoroughly and in detail, as vividly as possible, because we want to kind of trick our brain. And our brains are super sophisticated, but there are some tricks we can play, just the same as negative self-talk, where we really buy into that and believe what our brain is telling us. We can do the inverse and do some really effective things and get ourselves to move out of that place too. So imagine yourself in the situation now and not watching it. Like, first person, you're in the situation, you are putting your clothes on, you don't have to look like fabulous, it's fine, but you're imagining getting in the car, you're imagining turning the ignition, backing out of the garage, driving to Panera Bread. I don't know why that came to mind. I don't know. And you are going to meet with them and stay. Your goal is, I'm going to stay for an hour and I'm going to just try to behaviorally activate and not be at home in bed watching The Office for the millionth time, even though that sounds kind of great too. And then rehearse in your mind coping effectively. So really going through, like, what will I do if I really want to text and say, like, something came up? What am I going to do? So really rehearsing, and then practice relaxation after rehearsing, because putting yourself vividly in that place is probably going to be somewhat distressing. So really being able to, after you do all this hard work, maybe taking a hot bath or doing something that's soothing. Another target is not asserting needs. That can definitely come up in depression. You might not feel worth it. You deserve to have needs met, which results in decreased self-worth. So an intervention from the Interpersonal Effectiveness module is Dear Man. This is, again, an acronym. Surprise, surprise. Dear Man outlines a structured way of effectively making a request or a refusal of a request. Really what happens is that it helps to keep you on track in a conversation. And it's not saying, like, hey, if you do it this way, if you say it this way using this acronym, you're going to get your needs met. It's really just making it more likely that you're going to stay on track with what you're asking for, and increasing the likelihood that the person you're interacting with is going to stay in the conversation with you. We could come into a conversation, an interaction where we say, like, you know, I know you don't care, but this is what I need you to do. That is probably going to have the person's defenses come up if we say, like, I know how you feel. Like, I know you don't care, but this is what I need. That's likely not going to let the person stay in that conversation with you. You haven't even gotten to what you're asking for, and you've probably lost them. So this intervention is really great because it helps walk you through really clear and concisely, short and sweet. Try to set up your conversation in this way and have it be focused on your experience and how you feel, and very effectively and specifically ask for what you need, and then share how this might benefit the other person. That's where you're trying to get their buy-in. And again, it's not a guaranteeing that you're going to get what you're asking for. It's just making it more likely that the individual will stay in the conversation with you. So I'll read through these different points in case you guys can't see them from there or on your handouts. So D is to describe the situation. Again, really short and sweet. We don't need a novella here because we're probably, if we really draw it out, we'll probably lose the person. They'll not know exactly what to focus on. So the D is for describe. You're just very factually kind of setting the stage. Hey, this is what we're about to talk about. E is to express feelings and opinions. You're only talking about how you feel, not what you think the other person is feeling. This is not where we say, like, I know you don't care, but this is important to me. We're saying that, hey, yesterday this happened. And when that happened, this is what I noticed came up for me. I felt pretty invalidated, maybe. And then the assert is where we want to be super specific. This is where you're asking for something or refusing a request. And we want it to be super specific for 2 reasons. 1, so we get our need met. And 2, so the person knows what they're signing up for. So if we say, like, hey, yesterday, when you interrupted me and then didn't listen to what I was asking for, I felt pretty upset and invalidated by that. And next time when we're trying to have a conversation, I'm going to ask that you be more respectful. So that actually, what does that mean? What does respectful mean? You want it to be super specific. So that person might say, like, of course I want to be respectful, but their interpretation of what that is could be super different than what you're asking for. So you might say, when we're trying to have a conversation like that, let me finish, please don't interrupt me. And, of course, if you disagree, let's talk about it after. I'm asking though that you do let me finish, something like that. And the reinforce is where you're getting their buy-in. So you say, if you are able to do that, if we're able to work on this, then it's going to be more likely that we're both going to feel heard and validated. Of course, that is nice. We want that. The M is for mindfulness and appearing confident. So the MA, part of man. You want to make sure, this is why it's helpful to write these things out. So we're staying mindful and on track. The appearing confident is trying, you might want to practice this with somebody. You don't want to use like a quiet voice tone. You want to make sure you're making eye contact. You want to do things that display that you're serious. This is important. And the N is to negotiate. If necessary, you want to think ahead of time. What's your bottom line? What do you really, if they're not able to meet this request or if they're not willing, what's your bottom line? You certainly don't want to go in with that. But if, if they aren't able to meet your request, you want to have in mind what's a negotiation. And if the person keeps on saying like, nope, can't do that, I'm not going to be able to do that, then you'll want to put the ball in their court by saying like, it's really important that we try to figure this out. If you have ideas, let me know. I'd love to hear them. The V, this is certainly not part of Dear Man. It's part of the GIVE acronym that you see up there. That's about really trying to maintain relationships. That's relationship effectiveness. So the V and the E are in regards to that we always want to try to be validating. It's important, as we talked about before, as humans, we just really want to be seen and heard and felt understood. So it's important to use comments of saying like, I can understand, that I could see you really were strongly disagreeing with what I was saying and wanted to make sure that I heard that when you jumped in while I was talking, like trying to acknowledge understanding where they were coming from while also not saying, and it, it felt really invalidating for me when you did that. I didn't feel like I was being heard. So acknowledging their experience in any way that we can be super helpful. Whoops. And then easy manner. You'll want to use your mindfulness skills to see if that's something that you want to bring into the interaction. Some interactions you're not going to have it be more likely that you'll have the person stay with you in the interaction. If you come in like real serious and like, let's get down to the, bare bones of all this, easy manner can be super helpful when it's a relationship that you want to maintain. So you might put a little bit of humor in it, using a gentle voice tone, which is also part of give. That's the G in give. Doing something to kind of lighten it a little bit. Okay. So those were just a really quick overview of different interventions and targets with depressive symptoms that you might want to utilize within DBT if you're struggling with that or if a loved one is. And something that's really important that we did touch on when we were talking about the distress tolerance module is that acceptance is so important. And when we get in that place where things aren't changing, or maybe they're not changing as quickly as we would like them to, that can be a tough place to be. As a family member, a loved one, a provider, of the person who's suffering, that can be really tough to be there. So a skill, we wanted to end on this note, is that radical acceptance, which is part of distress tolerance, is so important because it helps us to reduce that burnout that comes from things not changing. And it helps us to move away from suffering. So when we all have reality, we all have our experiences that we've had and reality as is. And when something painful happens, that's unavoidable. Every day we're coming in contact with things we don't like, or varying degrees of things that are tough, that are painful, that are upsetting. And when we pair that with not accepting it, with saying that shouldn't have happened, they shouldn't have done that, I shouldn't have to deal with that, or I wish that this was different, this needs to be like, this isn't what it's supposed to be. If only this, then this. When we add that in, we put this layer on top of it called suffering. So we already have this emotional pain, and then we add on top of it suffering. So radical acceptance is being able to say non-judgmentally, just acknowledging what it is. We're not pushing back against reality. We're saying that, today I'm really feeling low. I'm really having a hard time getting started. I'm really noticing that I'm having a lot of thoughts about how much I don't like myself today. Because when we push back against that you're already having those thoughts of not liking yourself. And then if you put on top of that, oh my gosh, I shouldn't be doing this, I'm such a screw up for, thinking this way. You're just kind of layering this really fun cake that we get going there. So what we want to acknowledge is that radical acceptance is not approval or agreement. I'm not saying that I'm okay with feeling depressed. I'm not saying that it's okay that I don't like myself. It's saying that the fact is, acknowledgement, I'm having this thought, I'm having this hard time right now. So when we're able to do that, when we're able to work on acceptance, and it's not this thing where we reach it and we're done. Oh, I've accepted the fact that I have a lot of self-hatred. I'm gonna, be good now. It's not like that at all. We might have a moment where we are able to acknowledge and accept that I struggle with depression. I can acknowledge that that's something that comes up for me. And then in the next moment, we might be back in that place of, I shouldn't feel that, like I shouldn't have to deal with this. So it comes and goes. It's something that it's exhausting. You have to keep on turning your mind. That's one of the DBT skills. It's this kind of internal movement of saying, I'm going to try to accept. I'm going to try to acknowledge that this is what it is. So when we're able to do that, we really kind of make space for that pain that's there, and we can manage that. We can work on that. When we reject reality, that makes it so much harder. And we can't really, when we're saying this doesn't exist or this shouldn't be this way, you can't really change something that you don't accept or acknowledge. So we're staying stuck in that place. So in your handouts, there are quite a few resources. The first one on there is the suicide prevention hotline. Of course, if you or a loved one or someone you know is struggling with thoughts about hurting themselves, that's a very important resource to go toward if in crisis, in those moments. Behavioral tech is Marsha Linehan's website. It is the DBT website. There are tons of great resources there. The National Network of Depression Centers, all of these online websites have tons of resources for connecting you with literature, for connecting you with videos that help to educate different meetings or resources that are in the community as well relating to depression. And then there's Families for Depression Awareness, National Alliance on Mental Illness, Anxiety and Depression Association of America. I've also included some literature as well. Again, you can find those on those websites too. But these are some that have really great reviews. That workbook at the bottom is great. It's really kind of a self-help DBT workbook. That's helpful if you already have a lot of DBT skills to just kind of help you maintain that. All of these are just really great resources to help not feel so isolated in your experience with depression, as well as connect you with some different ways of managing that too. And that is it. Thanks, guys.